Good morning, everyone. Welcome to our first HIV Center Grand Rounds of 2021. Wishing everyone a happy and healthy new year. And I think a lot of us are feeling optimistic, hopefully, towards a better 2021 than 2020. So thank you for being here. I will remind people or let people know about our next upcoming Grand Rounds on January 21st. At the same time, that Thursday, we have Charles King from Housing Works, who will be talking on homelessness and harm reduction from HIV through COVID. So please join us on the 21st for that Grand Rounds presentation. So today we are fortunate to have two very interesting and important presentations and presenters. I'll introduce each one at a time, and then we'll shift midway to our second presentation. Just a reminder to everyone to keep yourselves on mute during the presentations. And if you have questions, you can start by putting them in the chat, or even just putting your name in the chat and asking your question live when the time comes. For those of you who are not online but just on phone, you would be able to unmute yourself at the time for the Q&A and discussion. But again, please keep everyone stay on mute until that time. So our first presentation is from Dr. Akanksha Anand, who is currently a postdoctoral fellow in the School of Nursing right here at Columbia University. She completed her Ph.D. in social policy at the Graduate School of Social Service at Fordham University, where she holds an academic teaching appointment and also has teaching appointments at the Silverman School of Social Work at Hunter College, CUNY, and the Columbia University School of Social Work. She received her bachelor's degree in psychology from the University of Delhi and an M.S.W. with a specialization in medical and psychiatric social welfare from Tata Institute of Social Sciences, Mumbai. Dr. Anand is the author of a book titled Remarkable Contributions, India's Women Leaders and Management Practices. She has taught courses in social psychology, research methods, statistics, social policy, program evaluation, community organization, group work, human rights and social justice, and social welfare programs. Her research focuses on examining the mental health of human service workers, hospitals, healthcare, employee well-being, managerial behaviors, and the sociology of gender, organizational leadership, hospitals as nonprofits, and social policy analysis. I'm very pleased that she's here today to talk with us about a very important and timely topic, particularly right now in the era of COVID. Her title is Mitigating the Negative Impact of Work-Life Stress on Health by Promoting Social Support, a study among frontline emergency room employees. I turn it over to you, Dr. Anand, and thank you for joining us today.
Thank you, Bob, for such a elaborate introduction. I feel it's so humbling. Thank you so much. Thank you. Hi, everyone. Good morning. A very good morning to everybody, and a very happy new year. My presentation today is about mitigating the negative impact of work-life stress on health by promoting social support and a study of frontline emergency room employees. I first want to thank the Institute and Theo and Rob and everyone for inviting me to make this presentation. Yes, it is important and timely, and I'm very grateful for this opportunity to present my dissertation work here today. Thank you for the opportunity, and I'm going to get started. I want to start by dedicating my work to the most important heroes of the time during COVID-19, which is the frontline doctors, who've really been important and crucial at this time, and burnout has been a serious problem. Work-life stress over a period of time results in burnout. So World Health Organization actually in 2019 recognized burnout as an occupational phenomenon. And the phenomena is basically a symptom of chronic work stress, and which is not successfully managed. And so work-life stress, in my presentation, you will see how work-life stress is managed over time. So I just do want to acknowledge the people who've contributed to my study. So a little bit of background of why this is important. Of course, hospital employees and frontline hospital employees, there's an urgent need for it because now the workforce is more women in the workforce, single parents in the workforce, dual learning couples in the workforce. Of course, with COVID-19, we do see a high caseload. We also see stressful environmental conditions in emergency room settings. For some of you who are aware of emergency room settings or not, let me give you an idea. There's always an interdisciplinary environment. There are nurses, doctors, resident physicians who are always there constantly working together. And the conditions are very stressful to work in environments like that. There has been a very high rate turnover and suicide rates amongst clinicians and frontline doctors. With COVID-19, there has been an increase in the rates of suicide and trauma, and people have reported PTSD as a result of prolonged exposure to such work stress environments. In 2022, the Labor of Statistics talks about a projected increase and a need of 14% of healthcare employees, frontline healthcare employees. And if the stress is not managed, how much does it cost us? It really costs us $1.125 billion a year in like just managing wellness programs. Why is this important? Why did I choose emergency medicine employees or emergency room employees? I'll give you a little background about that. So if you look at this graph, I know it's a lot on the PowerPoint, but I'll just break it down for you. So on the left side is the reported burnout, which is constant exposure to work-life stress leads to burnout. So you see that emergency room employees over the course of from 2011 to 2017, this is a longitudinal study that was done by Mayo Clinic Proceedings. And this is a pioneer study that has been reported that emergency employees are really dealing with a high rate of burnout and reduced life satisfaction and job satisfaction. And nearly half the physicians report burnout, and 1 in 4 nurses report burnout. That's why the study became really important as to what was happening and what are some factors that contribute to stress and what is it that we could do about it. This is another chart that explains the same thing. But if you see the orange box to your right, that basically says they report high burnout. So on the x-axis, we have work-life balance, and on the y-axis, we have burnout. So they're basically burnt out, and there's a lack of work-life balance in their lives. So they're highly stressed employees in emergency rooms. Why the burning question of work-life stress? Well, we all have stress in our lives, and I'm sure all of you all would agree with me that we have stress in our lives, but when it comes to healthcare employees, the consequences of error on the job are huge. So if you don't take action, it's going to have an impact on patients' quality and patients' quality of care and things like that. So there are stresses like time management. There's also a high workload in the ER. And then there is an environmental pressure in the middle, like organizational support, supervisory support, co-team management care, all those things that lead to work-life stress. And in this presentation, you will see me use work-life stress and work-family stress interchangeably, because at the end of the day, if we spend too much time at work, which is mostly ER employees spend over 12 hours at work, which obviously the stress and the fatigue goes home and has an impact on their family lives as well. That's why the study is important with time commitments. So now, what is work-life stress, right? So there is a dominant model suggested by the Greenhouse and Butel researchers in the Academy of Management. I actually sought permission to use this model for my dissertation and design it for my dissertation's needs. So basically, there are 2 forms of conflict that come from work. That is time-based, that is your time pressures and commitments, and the strain-based. So when at work, you have long hours of work in terms of time, it affects your family responsibilities like picking up your child, childcare, you have scheduling conflicts with commitments at home, and that is work to family. And family to work time-based stress would be taking care of a loved one, or when your emotions for a loved one interfere with your work performance. So that is work to family stress. And another type of work life or work, family stress is strain-based, which is when you have high caseload and you have little control over it because there's just so much of it that you cannot manage it because you don't you're either understaffed or maybe there isn't enough time with COVID. So it produces anxiety, and a lot of people reported being overwhelmed with the caseload they had. So it also interferes with your caretaking responsibilities of family members at home. And it also results in anxiety and fatigue. And same thing if for family, stress comes to work at times when you have to take care of a elderly person or somebody with stroke or something at home that might interfere with your work life. But for my dissertation, I only looked at work stress interference with family or work stress interference with life. So basically, this explains the process. I took two theoretical models, the conservation of resources theory and the self-regulation theory. Conservation of resources theory basically argues that we all conserve, retain, and maintain resources to deal with any stressful situation. So you have a potential time-based or strain-based stressor. And so when you get environmental or organizational supervisory support or social support in any form, it allows you to literally prevent that threat from really impacting your life, or maybe changing the way you would deal with it, or maybe self-regulating yourself or managing that stressor differently, but it'll change the way you adapt to the stressor or the way you respond to the stressor, which will ultimately reduce conflict and increase balance. So I use two theoretical models. COR is more an environmental resource-based theory. Self-regulation is a more individual-based theory, which looks at self-regulation and self-efficacy of employees. These are my hypotheses. I think pictures are say a more interesting story. So I'll just break it down. So I looked at the main effects of time management on work-family conflicts. So if we employees increased time management behaviors, would that reduce work-life conflict? If they got increased supervisory support, would that reduce work-life conflict? Those were my main effects. And interactive effects was as supervisors provided more time management trainings or time management, the interactive effect of time management and supervisory support, that would reduce conflict. I also included 5 control variables in my model. These are theoretically appropriate. And also I looked at the literature which talked about, if people had more control over their work, or if they had tenure, or they had a greater number of years in their work, or the kind of job they were doing, whether they were nurses or physicians, that impacted their work-life balance or work-life conflict. Also your relationship status, single, living with a partner, married, and the fluidity of relationship status, that also impacts your work stress. And also the number of children that you had impacted stress. So, or if you didn't have children. So I could put all those in the model as well. So my sample was this, the exciting part. So this is a sample. These are the frontline employees of a nonprofit hospital. They're doctors, nurses, physicians, physician assistants, resident physicians, and they qualified as human service employees because they were providing for humans in need. And there were 260 employees in the ER department. We had a response rate of 57%, which I think is really good. It took a little bit of work, but it's totally worth it. The strategies we used were in-person and online surveys. So we created a Qualtrics survey, and we also had a team of 4 research assistants who went into the break rooms in the ER to collect data. And I did in-person surveys as well at different hours and timings. I used descriptive inferential statistic, and I used the fancy hierarchical moderator multiple analysis, and I also used common method variance. These are my measures. They were self-report measures. I used the Carlson and Kutchmer scale for work-life and work-family conflict scale. The reliability was high. All the scales reported a higher reliability. I used the McCann's time management behavior scale. And for supervisory support, I'll say this more in my findings, but supervisory support is basically predominantly theoretically is divided into 2 pieces, emotional support and instrumental support. I'll talk more about that. We got very high, I have high reliability scores for that as well. And emotional support is more about caring for employees, and instrumental support is more about providing resources for their training and development for employees. So this is what we found. 64% of the people out of 57% of the responses we got, they were female. The average age was 25 to 34 years. Almost 1/3 of them had higher education or equivalent to master's degrees. They had job tenure of 25 to 44 years. I mean, there were people who worked in there longer, and I'll tell you why job tenure is important in my findings eventually. The ethnicity breakup was 44% were Caucasian, 19% were Asian, Hispanic and Latino 18%, and 7% African American. So this is a breakup of my hypothesis of what I found. So if you see all the hypotheses, hypothesis 1 through 3 are my main effects. So employees who received, who receive effective time management, did they reduce their work-life conflict? Yes, we had a significant effect of that. But people who also received increased instrumental support, meaning that they got training, they got help from the supervisor, did it lessen their work-life conflict? Yes, it did. And for hypothesis 3, these two are not significant, but hypothesis 2 and 3 are not significant, meaning that independently, either types of support, emotional or instrumental, did not have an effect on work-life conflict. But interestingly, hypothesis 4 and 5, if I put time management and supervisory support as an interaction effect in the model, we found a significant reduction in work-life conflict, meaning that if supervisory support was around time management and effective time management, it actually reduced work-life conflict in both scenarios with time management and emotional support and time management and instrumental support. So ISS is instrumental support and ESS is emotional support. So hypothesis 4 and 5 are significant. Now, the interesting part with the controls, what happened? So we looked at the 5 controls, which I showed you earlier. So with job control, there was a significant, even after controlling for job control, if people manage their time better, they're perceived to have better job control. Supervisor support still actually moderated the relationship between time management and work-life conflict. But the only thing that was not significant was tenure. So like I said, I'll tell you something interesting about tenure. We were thinking about how tenure actually could interfere with supervisory support. So maybe there are some alternative explanations for tenure out here, but all the other variables after controlling for relationship status, the number of children employees had, or the job types, job control, supervisory support consistently remained significant with time management's relationship with work-life conflict. These are just, I put the brief findings together for everyone to understand and take away from this presentation. Of course, employees, nurses, doctors, everyone experienced high work-life conflict. This data was collected right before COVID, but still there was high work-life conflict. People were less satisfied with their jobs. They were high caseload. Physicians and nurses, particularly out of the group, were far more affected by work-life conflict. There was strain-based stress, meaning that they felt tired, they felt anxious, they felt overwhelmed. This is also consistent with stress-based research. People experience these job-related somatic tensions, which is consistent with stress-related research. Also coping, getting a time break from a supervisor while you're on an emergency room floor is always not possible. So coping resources are limited. And we also found that support, whether it's emotional or instrumental from supervisors or organizations, it does act as a buffer. It helps employees to process stress and appraise it differently and prevent the threat that's going to happen. And also, it also allows you to appraise the stressor. And another interesting thing was the interactive effect, like I said, in hypothesis 4 and 5, where we saw that, time management with either types or sources of support, we found that had a significant impact on work-life conflict. These are for people who like quantitative statistics like I do. So first 2 are time management and emotional support. You can see to your right, I've circled it. The first 2 are the main effect. Time management significantly reduces conflict. And the step 3, which is time management and emotional support, that when you combine it and put it in the regression model, that's what reduces work-life conflict. So alone emotional supervisor support does not do much. But interestingly, when you look at the R-square effect, you see a 5.5 in the R-square model. You see an increase effect on the outcome variable of time management and emotional supervisory support. So time management does have an effect, but time management along with emotional supervisory support definitely reduces work-life conflict. We saw similar effects with instrumental support. I've circled again the same thing. We see the same thing with instrumental support here. Time management definitely in the main effect reduces work-life conflict, but with instrumental support also reduces work-life conflict. And we do see a R square of 5.4% that is explained in our outcome work-life conflict. This is a pictorial image, which is easier to understand. If you look at the circle point, you see that high time management, that point is where the employees were receiving high time management, high emotional support. You automatically see the curve of work-life conflict go down. You see the line of work-life conflict go down. So as employees got higher, they were managing their time better and they were getting more emotional support, you see work-life conflict go down. You see similar interactive effects with instrumental support as well. This is a simple to understand figure. And that's about it. Like any other study, it has limitations. We can't establish causal mechanisms because it's a cross-sectional study. We did not include all resources and conditions. Second, it's only limited to New York City because this was a nonprofit hospital in New York City, so we can't generalize about other healthcare organizations. Lastly, of course, we need to examine these nonlinear interactive patterns in other data sets and in other countries and other states, of course. The contributions of my research are, we're looking at conservation of resources theory, which is relatively new in studying stress and work-life conflict. It's just been 10 years that it's been, but it's talking about different resources and also using the self-regulation framework. And also in terms of policy, we need to look at more supervisory support policies. And in terms of practice, we need to look at rest and recovery breaks. If you're working too hard and too long, you need to get a rest and recovery break. So that's about it. Thank you.
Thank you very much for that really interesting and important presentation. I'm going to turn it over to my colleague, Stephen Sukumaran, to handle the Q&A and discussion. Stephen?
Thanks, Bob, and thank you, Akanksha, for a great presentation this morning. As I entered in the chat, if you have a question for Akanksha, please feel free to speak up, unmute yourself, or you can enter in the chat and I'll call on you or read your question for you. Theo?
Thank you, Akanksha, for the presentation. It was very interesting and very convincing what you had to tell. You mentioned that you collected the data before COVID.
Mm-hmm.
And I was wondering if you can speculate, and I know you don't have the data, but if you can speculate what the effect is of the increased work stress now in days of COVID, because the situation is different from when you collected your data. And at that moment, there was already a lot of stress. So how will that affect what you were seeing, do you think?
Yeah, definitely. I think that's a great question, Theo. It definitely will experience a high caseload with frontline employees. They will be far more stressed. And from my research, what we can clearly see is we need more social support mechanisms, not just from institutions, not just from organizations, but at an individual level as well. So we as supervisors or we as colleagues, we need to work in co-management team care. Like we need to support each other in terms of self-care. And if as a supervisor, you're taking a break, you're encouraging your mentee to take a break. So I think I do see that there are going to be increased levels of stress, but at the same time, as I've been reading the news and as there have been hospitals that are also looking at power charge rooms, and we also at the hospital have implemented something called the time pod breaks, which are basically 15 minutes break that you get from 4 hours, and you basically are on your phone, and basically you're on your phone or you're talking to somebody that's important in your life, or if you witnessed a death on the floor and you cannot take the patient right away, you can just take a break, tell your supervisor and take a break for 15 minutes to get off the floor to process your emotions. And what conservation of resources theory argues is that if you give your employees that kind of break, it allows them to conserve their resources and also replenish the cognitive resources that have been lost as a result of witnessing a death on the floor at that point. So basically COVID-19, I'm sure there were incidences like that. So we started giving more rest and recovery breaks, so they're called interim breaks. So if you give those, it allows employees to recover And in terms of support, I think communication needs to be open, co-management, team care communication needs to be open, and also supervisory support seems very important at this point. And so I do see that going towards, with the COVID situation in ERs, now providing rest and recovery breaks are very important for employees.
Thank you.
Yeah.
This is Bob. If I can just elaborate and add a comment. Thank you for that and that response, because and I hope some of this stuff gets published if it's not yet or in the process of. Some of what you just said matches my experience. We have a COPE Columbia program here in psychiatry, which has been in existence since back in March and April to help support all the frontline medical workers. And what you said, I think, is important to be verified in research. It's been our clinical experience that the importance of supervisory support and breaks. The challenge, particularly in the earlier days of COVID, and the concern is now with the increasing numbers that it's happening again, that there's very little room for breaks. And particularly early on, the workers felt like they just had to be on constantly, around the clock, and we're not getting the breaks. And we are seeing some of the suffering and the mental health stress because of that. So, what you're saying matches, my clinical experience in help working with the hospital workers. But it would be nice to see that, in verified by empirical research that would to further support the need for that kind of support and those kinds of breaks.
Yeah, I couldn't agree more with you, Bob. I think it's very important for these rest and recovery breaks, because then eventually I do, something interesting what Theo said and what you're saying is that prolonged exposure to stress does not just lead to burnout. It also has physiological outcomes. And like you're saying, we need programs like COPE Columbia to kind of have employees cope through these difficult situations. This also has an impact on cardiovascular outcomes. So yes, the publications are coming out with the American Public Health and different conferences I've been presenting at. And B, the thing is that we would eventually, I'm now interested, now that with my postdoc at Columbia, I'm now interested in looking at cardiovascular outcomes amongst employees, and also look at other things like blood pressure, heart rate, and things like that to see how this prolonged exposure impacts that, and how we could come up with wellness programs that actually fit the needs of the population we are working with.
That's great. Very, very interesting and very important. So thank you for this work.
Yeah, thank you.
Any other questions for Akanksha?
I bored them.
You were just so thorough. There are no questions. It was all very.
Yeah, that's a great way.
All right. Well, thank you again, Akanksha. And now we will move on to our next presentation. I'll turn it over to Bob for an introduction.
Okay, thank you, Stephen. And thank you again, Akanksha. And we're glad that you're here and close to us, and that, I think there'll be future collaborations and partnerships in getting to work with you.
Yeah, looking forward to it. Thank you so much. Thank you.
Great. Okay, so our second presentation is from Dr. Anthony Santoro, who is one of us here in the HIV Center for Clinical and Behavioral Studies. Dr. Santoro is a clinical psychologist and a postdoctoral research fellow here in the HIV Center. He received his master's degree in psychopathology from Columbia University and his Ph.D. in clinical psychology with a health emphasis from Yeshiva University. He completed an APA accredited clinical internship at Devereaux Advanced Behavioral Health, where he received intensive training in evidence-based behavioral interventions for children and adults with neurodevelopment and cognitive disorders. After graduating, he completed another year-long postdoctoral fellowship prior to the current one in clinical neuropsychology at the Center for Cognitive Assessment. Dr. Santoro's research is primarily focused on investigating the impact of early life adversity on the physical health and neurocognitive functioning of vulnerable youth and underrepresented populations. His current research aims to integrate behavioral and biological approaches to advance our understanding of and ability to treat and prevent HIV-associated neurocognitive impairment in young people living with HIV. I can see where we see some underlying similarities in terms of these two presentations, in terms of their approaches. Anthony will speak with us today on environmental stress and neuropsychiatric outcomes in people living with HIV in low resource settings. I turn it over to you, Anthony. Thank you.
Thanks, Bob. Okay, I'm just going to share. Okay, so a slight update to the title of my presentation today. So today I'll be presenting on early life stress and neurocognitive outcomes in people living with HIV in resource limited settings. So just to give an overview of my talk today. So first I'll talk about HIV in the brain, then I'll move on and describe HIV-associated neurocognitive disorders and the impact of early life stress on cognition. I'll follow that up by presenting findings, preliminary findings from 2 youth samples living with HIV. And then I'll wrap up by giving some main takeaways and future directions. So HIV in the brain. So upon infection, HIV crosses the blood-brain barrier and enters the central nervous system, where it there infiltrates and depletes immune cells and causes neuroinflammation. So the central nervous system serves as a viral reservoir, and this leads to chronic low-grade inflammation, neural cell damage, and structural brain abnormalities. And all of these contribute to the development of HIV-associated neurocognitive disorders, or HAND. So HIV-associated neurocognitive disorders, HAND, refers to deficits in cognitive functioning as a result of HIV infection. And it's this, so HAND is assessed via standardized neuropsychological testing. So HIV has been shown to preferentially impact subcortical brain regions. And so what this leads to is what's referred to as a subcortical pattern of cognitive deficits. And so we see impairments related to processing speed, which is the speed at which we process information and make decisions based on that information. Working memory, our ability to sustain attention and focus, our ability to keep information in our mind and manipulate that information. Executive functioning, so our ability to plan, organize, problem solve, our mental flexibility, judgment, and then learning and memory, so our ability to learn new information. I just want to note that in youth and children living with HIV, HAND can present as neurodevelopmental delays. And so HAND ranges in severity of impairment, which with the most severe form being HIV-associated dementia. However, milder forms of HAND, such as HIV-associated neurocognitive impairment, are the most common forms. So why is HAND important? So HAND represents one of the most common and functionally debilitating complications of HIV infection. And it's been shown to occur in up to 50% of people living with HIV, even with well-controlled viremia. Likewise, so it's very common. Likewise, HAND has been associated with poor disease and functional outcomes that substantially impact the quality of life of people living with HIV, including poor medication adherence, increased psychiatric symptoms, increased HIV transmission risk behaviors, lower academic achievement in children and adolescents, as well as difficulties completing activities of daily living, right? So such as cooking and managing finances and working. So what are the causes of HAND? So severe forms of HAND, such as HIV-associated dementia, are linked to elevated viral loads and immunosuppression. However, milder forms persist among people living with HIV on antiretroviral treatment. So milder forms present despite viral suppression. So our understanding of hand in the context of viral suppression remains incomplete. And with one of the most robust predictors of hand being nadir CD4 levels. So your lowest level of CD4, telling us, right, that not only does your current status matter, but your patient's history matters in predicting who might develop hand. That said, not all people living with HIV do develop hand. And this tells us or suggests that host factors such as environmental conditions may play a role in increasing risk. Likewise, there's a growing body of evidence that early life stress may be a particularly potent risk factor of hand. So what is early life stress? So early life stress is sometimes referred to as early life adversity, adverse childhood experiences. And it includes abuse, neglect, and household dysfunction in childhood and adolescence. So during critical periods of brain development. And early life stress for this presentation refers to, again, abuse, neglect, and household dysfunction, and is different than a traumatic event that has a discrete beginning and end. So experiences such as physical abuse, emotional abuse, sexual abuse, living with a parent with household member with mental illness has been shown are prolonged stressors, right? And they result in toxic stress, right? And toxic stress is from stressors that are severe, frequent, or prolonged, and uncontrollable, right? And these stressors are important because they really color the child's understanding of the environment, right, as unsafe and unpredictable, right? And this leads to hypervigilance and low-grade stress, even when the stressor is not currently present. So just to talk a little bit about the neurobiology. So toxic stress leads to chronic activation of our stress response. And over time, this leads to a dysregulation of our neuroendocrine and immune systems. Okay, so one well-researched area is the link between early life stress and hypothalamic pituitary adrenal HPA axis dysregulation. So the HPA axis regulates our body's response to stress through the release and inhibition of stress-induced hormones. However, chronic and prolonged activation of our HPA axis leads to a disruption in the negative feedback loop, right? And that's the mechanism that shuts off our stress responses. And so, when there's disruption in the negative feedback loop, what ends up happening is that these stress-induced hormones, which at high levels, definitely can be neurotoxic, are allowed more time to play in the brain, right? So the brain tissue is exposed to these hormones for longer periods of time. This results in chronic neuroinflammation, a heightened immune activation, and damage to the brain architecture. So there's much evidence of the pathogenic effects of early life stress on the brain, both in terms of the structures, so the physical structures, as well as the brain functions. So early life stress has been linked to lower cerebral volume, so smaller brains. And in regards to specific areas of the brain, early life stress has been shown to impact the prefrontal cortex, which is important for executive functioning, judgment, self-regulation, the hippocampus, which is important for learning and memory, the amygdala, which is also important for learning, as well as emotional responses. And there's been research that shows actually an increased volume in the amygdala among adults with histories of early life stress, and a sensitization where their amygdala is responding and activated more readily. So among people living with HIV, early life stress is very common, right? With estimates of 50 to 76% of people living with HIV have endured some form of early life adversity or stress. And among people living with HIV, early life stress is associated with increased HIV transmission risk behaviors, adult trauma, re-traumatization, re-victimization, poor mental health outcomes, increased depression symptoms and PTSD symptoms, as well as poor HIV outcomes. So missed care visits, poor ART adherence, HIV disease progression, and an overall poor quality of life and disability. So so early life stress in the context of hand. So it's important to point out that both early life stress and HIV, they both independently predict persistent inflammation and a degradation to our immune system. And this impacts the neural structures and functioning of the brain and increases hand risk. They also share underlying etiological mechanisms, specifically HPA axis dysregulation and neuroinflammation. Likewise, they overlap in neuropathology and have been shown to really impact the frontal subcortical systems. And so all of these commonalities suggest that there's a possible double burden of early life stress in HIV. And that early life stress-related neural changes may predispose the brain to experience exacerbated neuropathological effects of HIV. So early life stress creates a brain that is particularly impacted by HIV infection. And the combination of early life stress and HIV may further potentiate the development of hand. So further research investigating the combined effects of early life stress and HIV on cognitive functioning is warranted. So of the few studies that have looked at this relationship, they've all been on among adults living with HIV and have shown that adults living with HIV with histories of early life stress do show poor neurocognitive functioning compared to people living with HIV without histories of early life stress. And these deficits and discrepancies in neurocognitive function persist over time. So people living with HIV with high early life stress histories show these deficits even after improved HIV disease status and virologic control. Likewise, neuroimaging studies of people living with HIV have shown that adult people living with HIV with high early life stress show abnormal neural morphology and functioning. Also, high early life stress and nadir CD4 levels have been shown to account for similar and independent amounts of variance in brain volumes. And this is striking because, as I mentioned earlier, nadir CD4 levels is are one of the most robust predictors of who will develop hand. So in terms of research gaps, so early life stress is an important environmental or psychosocial factor that's associated with increased risk of hand. Further research is needed to clarify the impact of early life stress on neurocognitive functionings among vulnerable populations of people living with HIV at high risk for hand. These include adolescents and young adults, people living with HIV with perinatally acquired HIV, youth who are born with HIV, mainly because these youth are exposed to HIV and the accompanying neuroinflammation for the entirety of their brain development, as well as people living with HIV in resource-limited settings, such as low and middle income countries, where the burden of HIV and hand is highest. And people living with HIV commonly are exposed to environmental factors such as resource scarcity, chronic stress, that further negatively impacts neurodevelopment and cognitive functioning. So this leads me to my first question. So does early life stress impact neurocognitive functioning in young adults? So are the effects that we see in adult people living with HIV, do we see those effects in kids living with HIV? So preliminary data comes from Reuben Robbins' NASA study, which is a study to adapt NeuroScreen, which is a tablet-based application that screens for neurocognitive impairment. So to adapt NeuroScreen for use in youth living with HIV in South Africa. So data comes from 72 South African perinatally HIV infected adolescents between the age of 14 and 17 years from Cape Town. The mean age was 15 years old. Almost 53% were female. 90% were right-handed. And participants completed the NeuroScreen app, as well as a gold standard neuropsychological test battery and psychosocial measures. In terms of the predictor variable was early life stress as measured by the Adverse Childhood Experiences Scale, which is comprised of 10 dichotomous items measuring abuse, neglect, and household dysfunction. So total scores were created by summing affirmative responses, and then total scores were collapsed to attenuate scores at the higher end of the distribution. Likewise, similar to previous studies, I created a dichotomous grouping variable to sort participants into a high early life stress group and a low early life stress group. And with the high early life stress group being indicated by 2 or more ACEs. In terms of outcome variables, my outcome variables were NeuroScreen subtests, particularly measuring processing speed, working memory, and executive functioning, as well as a paper and pencil measure of executive functioning from the NEPSI. For analyses, I conducted Pearson correlations, bootstrapping 5,000 samples. I also conducted independent t-tests to test for differences between the high stress versus low stress group. Again, bootstrapping 5,000 samples and calculating Cohen's d as a measure of effect size. So in terms of individual stressors, so in our sample, the most commonly reported stressors were parent divorce, separation, and household member alcohol and drug use. And 1/4, right? So 1/4 of these youth report that they have a household member who's abusing substances, which is really remarkable. In terms of the least frequently reported stressors, very low rates of sexual abuse, domestic violence, and living with a household member with mental illness or suicidality. So in terms of total prevalence of stress, right? So more than half, 58% of these youth reported at least one early life stressor, right? And these aren't just minor annoyances, right? Abuse, neglect, household dysfunction, right? So 58% reported at least one. And even more strikingly, almost 35%, so more than a third of these kids reported enduring multiple adversities, multiple early life stressors. So in terms of the relationship between early life stress and our neurocognitive tests, we found a significant relationship between ACE total scores and measures of processing speed, as well as the paper and pencil measure of executive functioning. And this measure particularly measures our ability to inhibit automatic responses. So when testing for differences between the high stress and low stress group, and again, this is only among people, youth living with HIV, we found, again, significant differences between the high and low stress group in terms of processing speed, with Perinatally HIV-infected youth exposed to high stress reported performing poorer on these tasks and taking longer. Similarly, HIV-infected youth in the high stress group made almost double the amount of errors on the inhibition task, right? So the high stress group was slower, right? And made more errors, right? And all of these effects were of a medium to large effect size. So this leads me to my second question. So does early life stress impact cognitive functions and mental health differently in people living with HIV compared to HIV negative peers? So data for this study comes from Ruben Robbins' Thailand study, which is a study that aims to improve how we measure HIV-associated neurocognitive impairment among adolescents and young adults living in Thailand. And so the sample was comprised of 100 Thai adolescents and young adults between the ages of 13 to 23. We had 50 perinatally HIV-infected youth and 50 HIV-negative controls recruited from Chiang Mai and Bangkok. So the average age of participants was 18, 50% female, 89% right-handed. And participants completed a gold standard, again, neuropsychological test battery and psychosocial measures. For the second study, the predictive variable early life stress was measured by a stressful life events checklist, which lists 12 social environmental stressors experienced over the last 12 months. And this included family member hospitalization, death in the family, parent caregiver incarceration. Again, affirmative responses were summed to create a total score. And a dichotomous grouping variable was created to differentiate stress exposed versus unexposed youth. So youth who reported one or more of these stressors in the past year was coded as stress exposed. In terms of outcome variables, subtests from working memory and processing subtests from the WISC-WAIS were administered. Again, we looked at executive functioning using subtests from the DCAFs. We also looked at depression. And so for youth under the age of 17 were administered the CDI, and youth over 18 were administered the CESD. So depression total scores were standardized, so transformed into Z-scores and then combined. And also a dichotomous variable was created to indicate clinically significant depressive symptoms. So CDI scores over 17 and CESD scores over 16. For analyses, group differences were assessed via chi-square and odds ratios. I also conducted a Kruskal-Wallis test to examine differences between the four groups, which were HIV positive stress exposed, HIV positive stress unexposed, HIV negative stress exposed, and HIV negative stress unexposed. And so post hoc pairwise comparisons were conducted for significant differences, applying the Bonferroni correction for multiple tests. Additionally, a two-way ANCOVA tested for interaction effects by status and stress exposure on depression scores. And so we controlled for age and sex, and again, bootstrapped 5,000 samples. So in terms of stressors, the most commonly reported stressors among the sample were having a family member who was hospitalized or having a family member who was very sick. And for both of these, the HIV positive group reported both of these at higher rates. Also, the HIV positive group 44% of them reported at least one stressor in the past year, and 22% reported 2 or more of these stressors in the past year. And really remarkably, so the HIV group was 4.42 times the odds of enduring multiple stressors compared to the HIV uninfected controls. So looking at differences by status and stress exposure. So across groups, the HIV negative youth who were stress unexposed, right? So no stress, no HIV, across measures performed best. Similarly, or on the other hand, the group of HIV positive youth who were stress exposed performed poorest across tasks. Across groups, we found significant differences in regards to processing speed, with the HIV negative stress unexposed group performing better than both the HIV positive stress exposed and HIV positive stress unexposed groups. So the HIV negative stress unexposed group performed better than all of the HIV positive kids, right? We also saw significant group differences in terms of complex attention. And so this is where it gets interesting. So post hoc tests revealed that the significant differences were between the HIV negative stress unexposed and the HIV positive stress exposed groups. So the differences between the HIV negative stress unexposed and the HIV positive stress unexposed group were not significant. And we saw this similar pattern in terms of executive functioning. Again, with the differences between HIV positive and HIV negative groups really being contained to the HIV positive kids who were also stress exposed, right? And I just want to point out that, so these are scaled scores with a mean of 10 and a standard deviation of 3, right? And so when we look at complex attention, the average score, scaled score is 5.59, and that falls in the borderline range of functioning, right? So between the 8th and 3rd percentile, so definitely a deficit. So in terms of depressive symptoms, we conducted 2-way ANCOVA, adjusting for age and sex, and we found a significant interaction effect by HIV status and stress exposure on depression. And here's an interaction plot depicting that. So where was the interaction, right? So when we looked at the stress unexposed groups, right, we see that we see that the HIV positive group and the control group are reporting similar rates of clinically significant depressive symptoms, right? So no meaningful differences in the stress unexposed group. However, when we look at the stress exposed youth, right, we see much higher rates of clinical depressive symptoms among the HIV positive group, right? So the HIV positive youth who are stress exposed had significantly greater rates of clinically significant depressive symptoms compared to controls. And among people, the youth living with HIV, the stress exposed HIV positive group had 6.6 times the odds of clinically significant depressive symptoms compared to the HIV positive stress unexposed group, right? So a few takeaways. So early life stress is common among adolescents and young adults living with HIV. Again, with our Cape Town study showing 58% of these youth living with HIV endorsing one or more ACE. And early life stress among, and so early life stress is both common and reported at higher rates than uninfected peers. Likewise, these youth have higher rates of multiple early life stressors. And this is important because a gradient nature between early life stress and neurocognitive functioning has been found, right? So the more early life stress, right, the greater number of early life stressors has been associated with poorer outcomes. So this does matter, that these youth are enduring or have higher rates of multiple early life stressors. So early life stress is an important environmental and psychosocial factor of hand risk, right? And previous research has shown that it may predispose our brains to greater HIV-related neuropathological effects, right? And so early life stress's impact on cognitive functioning. So in the literature, it's been proposed that perhaps these effects of early life stress aren't present in adolescence, right? And that more behavioral symptoms present in earlier years, and that neurocognitive impact and biological impact of early life stress isn't seen till middle or later adulthood. And so what these preliminary results are showing is that among young people living with HIV, early life stress's negative impact on cognitive functionings is already present by adolescents, right? And we saw significant differences among these youth living with HIV in terms of processing speed, complex attention, and executive functions, right? With the HIV positive stress exposed group performing worse across these domains. So these results extend previous findings in adult people living with HIV that indicate a double burden or suggest a double burden of early life stress and HIV on neurocognitive health, right? And so to make it simple, early life stress plus HIV is a detrimental combination. So now to lighten it a bit, here's a silly cartoon about another bad combination. So guns and alcohol, hey, I've got your guns and alcohol, right? So maybe okay separately, maybe not, but definitely a bad combination. I also want to stress, though, that despite the high rates of early life stress among HIV positive youth, these youth are really resilient, right? These youth are incredibly resilient. And so, youth living with HIV in low and middle income countries without additional stressors, right? Living with a chronic illness, right? Developing with a chronic illness, navigating the challenges of adolescence and young adulthood with the chronic illness is stress in and of itself, right? And so kids who have to manage that, but don't have to manage other additional stressors, they're resilient. They did great, right? So we found generally intact average range neurocognitive functions, right? And performances on neurocognitive tests that were comparable to uninfected peers, right? We also found similar rates of depression between the HIV positive youth without additional stressors, similar rates of depression compared to uninfected peers. However, these youth may be differentially impacted by stressors in regard to their neurocognitive functioning and may experience higher rates of depression in the presence of stressors, right? And so I just want to point out that the specific cognitive functions that were impacted among the HIV positive youth who were stress exposed, right? Complex attention, again, in the borderline range, right? And executive functioning. So these are abilities, right? And cognitive domains that are really important for the successful transition into adulthood, right? Navigating increased academic and social demands. And so HIV positive stress exposed youth may be at particular risk for poor developmental outcomes. And they may require closer monitoring as well as additional supports as they make that transition. So in terms of limitations, results were based on preliminary data from small samples, and replication is needed in larger samples. Early life stress was measured differently across studies, right? Cognitive functions were measured differently across studies, and this precluded, a meaningful cross-cultural comparison. And I just want to note that there is a need to improve our measures, how we measure cognitive functioning, and how we measure, a standardized way of measuring cognitive functioning, particularly in youth living in low and middle income countries where resources are limited. And that's why the work that we do at NeuroScreen, which is, potentially scalable and, can be translated, cross culturally, is really exciting for us. Another limitation was that the early life stress measures were not exhaustive, right? And measuring early life stress in youth, there really isn't a fantastic way of doing this, right? And so we need additional measures that are both age appropriate and culturally relevant, meaning that they capture the common and potentially impactful specific stressors that youth are exposed to in resource limited settings, which may be different than those experienced by youth in the United States. Lastly, a potential limitation was we found lower than expected rates of certain ACEs in study one, particularly in regards to, low rates of living with a household member with mental illness and low rates of sexual abuse. And, it's unclear whether youth misinterpreted this question or if there really are such low rates, which I'm hesitant about, or if this is related to youth's hesitation to endorse these items because they're so sensitive in nature. So in terms of future directions, enhancing our ability to treat and prevent HAND is critical to reducing the burden of living with HIV across the globe. And enhancing our ability to treat and prevent HAND has the potential to substantially improve the health and functioning of people living with HIV across the lifespan, right? There's a need to clarify HAND risk factors, pathogenic pathways, and modifiers. And in doing so, this will allow us to identify people living with HIV who are most at risk, right? So we could focus our resources on people living with HIV at highest risk. Clarifying pathogenic pathways and modifiers is also important to identifying salient intervention and prevention targets that can be used for intervention development. Improving our understanding of how early life stress impacts HIV neuropathology across the lifespan is critical, right? And so it's because of the high rates of early life stress among people living with HIV, it's really important that we pick apart what's the neurocognitive impacts of HIV, what's the neurocognitive impacts of early life stress, right? And what are the combined, what's the combined impact? And lastly, not all people living with HIV exposed to early life stress develop HAND, right? And so this suggests that there are other host factors that moderate the relationship between early life stress and HAND, right? And among youth living with HIV, it's unclear really if these truly are cognitive weaknesses or delays, right? And this is why it's important to look across the lifespan at these relationships, because do these youth catch up to their uninfected peers, right? Is it not that complex attention is, necessarily a deficit, but is it just a little delayed? Whereas the HIV uninfected peers, right, develop these abilities sooner or quicker than HIV positive kids. So longitudinal research is needed that examines multiple risk factors concurrently, including environmental and genetic risk factors. And we have some exciting pilot work going on right now in Thailand, where we're looking at, in a small pilot sample, where we're looking at the combined, the ability to look at the combined impact of early life stress and a genetic marker that's associated with HAND in adult people living with HIV. So exciting stuff coming. Okay, so thank you. That's it. I just want to acknowledge my fantastic team that are just so effective and supportive. A big shout out to my mentor, Ruben Robbins, who's so generous with his time and resources with me, as well as Chris Ferreras, who just is the glue that keeps everything together. So thank you.
Thank you, Anthony, for your rich and thoughtful presentation. So once again, I'm turning it over to Stephen to monitor the Q&A and discussion. Thanks.
Thanks, Bob. And yes, thank you, Anthony, for some really fascinating work that you're doing. So a reminder to everyone, if you have a question, please enter your name in the chat. We'll start off with a question from Charles Gonzalez. Charles asks, all the youth were perinatally infected, correct? That is, none of the youth in the studies were behaviorally infected?
Yes, so none of the youth were behaviorally infected. They were HIV was perinatally acquired in across both samples. And that's important because unlike behaviorally infected peers, right? Children who are born with HIV are exposed to the HIV in their brains throughout their entire neurodevelopment. And so that is an important point.
If you have a question, feel free to unmute yourself to ask it. Question from Ruben Robbins. Great talk, thanks. Do you have any thoughts on what kinds of interventions we should use or test or try?
Yeah, I think that, well, yes. And again, there needs to be work in this regard, right? However, if executive functions are impacted, right, which we saw across studies, right? It's understandable that, these kids are going to have a difficulty with medication adherence and monitoring their illness. So definitely interventions that, aim at increasing our executive functioning, our organization skills, our planning skills, our problem solving skills might be particularly impactful, as well as, increasing skills related to emotion regulation, right? So like early life stress has been associated with emotion dysregulation, right? So, having these youth learn to better self-regulate their emotions can be quite impactful. And also, where does adversity and early life stress occur, right? It occurs in the home. So I think that interventions that are focused on the family and parents can be potentially impactful as well.
I'm wondering how you would go about those interventions with the parents without potentially causing further harm with the children involved. Like, would you be putting them at risk by introducing interventions with the parents, by, you know, giving the assumption that there is a need for it?
So, I mean, I hope not, right? I mean, of course, that's always a concern, right? But, you know, I think that, you know, it depends on your approach, right? If you go into a home or a family, right, and you want to, you know, tell them the ways to do things, right, the right ways, then yeah, they're not gonna buy in, or right. However, if you approach them in a way to support them, right, you know, I think that's really the key here. Also, these children, you know, the things that we talked about today, they're not, you know, these children are physically, sexually abused, right? Right. So we're talking about sexual abuse. We're talking about physical abuse, right? We're talking about physical neglect, right? We most certainly should help these children, right? We most certainly should go in and help these families, right? And I just don't want to fall. I just like really have strong feelings about, you know, not asking about something, or because we're scared of it being yes, right? Because silence keeps these kids suffering, right? And so you know, I'm hesitant, or I'm always for, you know, doing the work, doing the screening, and doing the follow-up work, right? And staying in contact with these families, working with them.
Any other questions?
I could raise one. It's Phil Korniski. Great talk, Anthony.
Thank you.
Can you hear me okay?
Yep.
I was just wondering, you know, if you think about interventions, do you think that you would be targeting mental health, or do you think that there can be interventions that could potentially target executive functioning or other neurocognitive, you know, developmental, you know, tasks, and potentially, you know, improve this? Or do you think that once you see these deficits, that there's not much to be done at that point?
So it's tricky, right? You know, there are cognitive remediation interventions, right? It is tricky. However, you know, I think that it's important to differentiate, you know, what's a neurocognitive ability, right? And then what's a behavioral skill, right? So I think you can, even if, you know, these deficits exist, right? You can teach skills that make these deficits less impactful on functioning, right? So we know that executive, you know, kids who have deficits in executive functioning are going to struggle with planning and organizing and managing themselves, right? So behavioral interventions that increase those skills, right? That give behavioral strategies to better manage medication, right? I think would be appropriate. You know, and combining it with a cognitive remediation aspect might be, you know, impactful. So more work is definitely needed. And
Anthony, hi, my name is Emma, and I just wanted to introduce myself quickly.
Hi.
I'm actually a postdoc in child psychiatry at Columbia, but I have an interest in the work you guys are doing at the HIV Center, and I can't help but just speak up because I just recently finished my PhD at Rutgers with Tracy Shores, who's in behavioral neuroscience, and we actually, for my dissertation, provided this combined silent meditation and aerobic exercise program for women living with HIV in Newark. And I'd be happy to just, you know, touch base with you. Maybe we could have a call separately, because the program it's actually specifically, or I should say, it's not specifically designed for people living with HIV. We've provided it particularly for people living with trauma. And the idea is that potentially it targets kind of learning and memory processes and emotion regulation skills by like getting the heart rate up, but then also combining it with meditation and trying to target rumination. And we found some really positive effects, which I'm currently trying to write up and publish, but I'll email you. Maybe we can have a call, because I think
follow up, because
it'd be so great to.
Great. And that sounds like
to prepare for children. Yeah, it's so important. So thanks for all that you do, and thank you for sharing your work. I just wanted to to say that because I can't help but sit here quietly.
Oh, thank you. Thank you.
Yeah.
If there are no other questions, I'll turn it back to Bob for closing remarks.
Okay, thank you, Stephen. Thank you, Anthony. Thank you, Akanksha. Again, two really great talks, different topics, but with underlying similarities and, the notion of impact of stress on, behavioral functioning, but also, biological substrates and all of that, which I think is important work for our center to carry forward. So I want to thank you both very much for an excellent grand rounds today. Again, I want to wish everyone a happy new year, healthy new year, stay safe. Hopefully we can all get vaccinated in the not too distant future. And as a reminder, again, please join us on January 21st for